anytime, anywhere through the recorded sessions. Then also we provide notes with CME-based question answers, MCQ, and full zone for self-assessment. Then MCQs are also there from beginner level to expert level. Then student can also book a slot for personalized counseling session. Then also in Auricle, we provide subscription plans starting from basic to premiums. So basic plan is of 3 months, standard plan is of 6 months, and premium plan is of 12 months. So in premium plan, we provide services like pre-recorded class, slide doubt clarification, one-to-one personalized guidance, notes, quick revision examination module, and also this plan costs around 50,000, and also for instant 20% discount, you can use my code, that is Aanchal 20. So let's start with the today's topic, and also there are some core feature of internal marathon series that we provide rapid revision of all the important topics. Then also volatile fact are discussed here, multiple choice question will be covered, and we assure top-notch grades in the examination. So in today's class, we're going to discuss about types of respiratory failure, Casson's disease, functional residual capacity, residual volume, dystonic index, airway resistance, time vital capacity, periodic breathing, and cyanosis. So let's start with today's topics. So first, we're going to discuss about airway resistance. So airway resistance always we cover under utilization of energy. So whenever we do any kind of work, okay, so if we consider during the work of breathing, so the energy is utilized to overcome 3 types of resistance, and though resistance includes airway resistance, then another we have elastic resistance of lungs and thorax, and third we have is non-elastic viscous resistance. Okay, so first we're going to discuss about airway resistance. So as we can see in this slide also, that this is the resistance offered to the air in the respiratory passage, and it has high resistance in the large bronchi and bronchioles, and low resistance in the minute terminal bronchiole, minute terminal bronchioles, and the number of minute pallar terminal bronchiole are high, approximately 65,000. So basically, what is airway resistance? So this is the resistance that is offered to the passage of air through the respiratory tract. Okay, and here resistance increasing during bronchial constriction, which increases the work done by the muscle during breathing, and also work done to overcome the airway resistance is known as airway resistance. Okay, then if we talk about the elastic resistance of lungs and thorax, so here this elastic resistance is basically whenever energy is required to expand lungs and thorax against the elastic force, and the work done to overcome the elastic resistance is known as compliance. Okay, then third we have non-elastic viscous resistance. So here also energy is required. Here also energy is required to overcome the viscosity of lungs tissue and tissue of thoracic cage. Okay, and work done to overcome the viscous resistance, here it is known as tissue resistance. Okay, so this is all about the airway resistance, where we have learned under the heading of utilization of energy. Then next we have residual volume. So already we have covered this in the lung volume and capacity. So whenever we talk about residual volume, so residual volume is the volume of air remaining in the lungs even after forced expiration. Okay, like if I inhale very forcefully like this, and if I exhale all the airs, but still some amount of air will be remaining in the lungs, that is known as residual volume. Okay, so normally lungs cannot be emptied completely even by forceful expiration. So some quantity of air always remain in the lungs even after the forceful expiration. Okay, so this refers to the minimum volume of air that left it has been drained or. Okay, so if we talk about the significance, what is the significance of residual volume? So significance is there that it helps to aerate. It helps to aerate the blood in between breathing and during expiration. Okay. And second significance that it maintains the contour of lungs. Okay. Then talking about residual volume. So the normal range or the normal value of residual volume is around 1200 ml or 1.2 liter. Okay, so this is all about residual volume. Then next we have functional residual capacity. Okay, so when we talk about functional residual capacities, functional residual capacity is the volume of air remaining in lungs after normal expiration. Like if I inhale, then I exhale normally, like in tidal respiration. So what happens, the amount of air that is residing in our lungs, that is considered as a functional residual capacity. Okay, but for determination of FRC, we have a formula that FRC is equals to ERV plus residual volume. ERV is expiratory reserve volume. So it will be around 2200 ml. Okay, so this is the volume of air remaining at the normal expiration, and it is the balance point between the tendency of the chest wall to spring outward and lungs parenchyma to collapse inward. Okay, then in the condition PPP, then emphysema, erect position, etc., there will be increase in FRC, while during anesthesia, obesity, pregnancy, supine position, it will lead to decrease. Okay, then FRC is about 2100 ml. So oxygen gets stored is about 440 ml of oxygen breathing air, and pre-oxygenation rapidly expands it, and it avoids undue fluctuation in partial pressure of oxygen, and also it prevents atelectasis by maintaining a state of partial inflation. And here PVR works of breathing, and V and by P volume by pressure mismatch at least at FRC, and airway resistance is also low at FRC. Okay, now next we're going to know about the measurement, that how we can measure this functional residual capacity. Okay, so for measurement, usually we do it by three methods. First, we're going to discuss about helium dilution method. Okay, so what is helium dilution method? What happened during this process? Respirometer is get filled with air containing a low quantity of gas, and that gas we considered is helium. Okay, so initially what happened? The subject breathes normally. Okay, so initially we keep the subjects to breathe very normally. Then after the end of expiration, the subject breathes from respirometer. Okay, so what happened? Helium from respirometer will enter the lungs and start mixing with the air that is already present inside lungs. Okay, now what happened? After few minutes of breathing, the concentration of helium in the respirometer become equal to concentration of helium in the lungs of subject of helium. Okay, now once we reach the equilibration of helium between respirometer and lungs, concentration of helium in respirometer is determined by using a formula that is known as FRC is equals to V C1 minus C2 upon C2. Okay, so here C1 is the initial concentration of helium in the respirometer, then C2 is the final concentration of helium that is present in respirometer, and we have the initial volume of air that is present in the respirometer. Okay, so this is how we can measure it. Okay, so Another method we have is nitrogen washout method. Now, what happened in this method? Here, normally concentration of nitrogen in air is 80%. Okay, so if total quantity of air or total quantity of nitrogen in the lungs is measured, the volume of air present in the lung can be calculated. Okay, and that can be calculated again by a formula that also we're going to discuss. So, what happened for during the procedure to measure FRC, subjects is asked to breathe very normally. Okay, then at the end of normal expiration, the subjects inspire pure oxygen through a valve and expire into Douglas bag. Okay, and this procedure is repeated for about 6 to 7 minutes. Okay, until the nitrogen in lungs is displaced by oxygen. Now, nitrogen comes to the Douglas bag, and after following various factors are there that is used to calculate the functional residual capacity, and also we can determine it by using a formula, that is FRC is equals to C1 into V upon C2. Okay, so here again V is the volume of air collected, then C1 is the concentration of nitrogen in the collecting air, and C2 is the normal concentration of nitrogen in the air. Okay, so by using this formula, again, we can calculate the FRC. Then third method we have is plethysmography. Okay, now what happened in this method? This is also a technique that is used to study the variation in the size or volume of a part of the body, such as limb. Okay, so that this plethysmography is a instrument, okay, which is used for this purpose, and whole body in plethysmography is basically the whole body is the instrument that is used to measure the lung volume, including residual volume. Okay, so this plethysmography is based on the principle of Boyle's law of gas. Okay, so already we know what is Boyle's law of gas. This states that volume of air of a sample of gas is inversely proportional to the pressure. Okay, so we know Boyle's law states this relationship. Okay, so to pressure of the gas at constant temperature, and in this condition, what happened? Subject sits in an airtight chamber of the whole body and plethysmograph and breathes normally through a mouthpiece connected to a flow transducer that is known as pneumatograph. Okay, then it detects the volume changes during different phases of respiration, and after normal breathing of a few minutes, the subject breathes rapidly with maximum force, and during maximum expiration, the lung volume decreases very much, but volume of gas in the chamber increases with decrease in pressure. By measuring the volume and pressure changes in the chamber, volume of gas is calculated by using a formula, that is P1 into V is equals to P2 V minus delta V. Okay, so here the P1 and P2, we both are the pressure changes, and V is considered as the functional residual capacity, and delta V is the changes in volume. Okay, so this is all about, and by using these three methods, we can easily determine the functional residual capacity. The next we have time vital capacity, and this is also known as force expiratory volume. Okay. Okay, so what is this? What is this time vital capacity? So here, this is the volume of air which can be expired forcefully in a given unit of time after a deep inspiration. Okay, and this is also known as time vital capacity or force expiratory vital capacity. Okay, so here it is a basically dynamic lung volume, and here we have three types, that is FE V1, then FE V2, then FE V3. Okay, so FeV1 is the volume of air expired forcefully in 1 second. V2 is volume of air expired forcefully in 2 seconds. And V3 is volume of air expired in 3 seconds. Okay, so it is the fraction of vital capacity that is expired during first second. Okay, that is FeV1. During second, that is FeV2. And during third second, that is FeV3 of fourth expiration. Okay. So here we also have the percentage, okay, the normal value of time vital capacity. So here the normal value always says that FeV1 is the 83% of total vital capacity, FeV2 is 93% of total vital capacity, and FeV3 is 97% of total capacity. And after third second, what happened after third second? After third second, there will be 100% of total vital capacity. Okay. Then if we talk about the significance and determination of this FVC, so this vital capacity may be almost normal in some of the respiratory disease, and this forced expiratory volume has greater diagnostic value as it decreases significantly in some respiratory disease, and it is very much decreased in obstructive disease like asthma, like emphysema, and also it is slightly reduced in some restrictive respiratory disease like fibrosis of lungs. Okay, so this is all about time vital capacity. Now, next we have the another thing, that is dyspnoic index. Okay, so what is this? This is the index between breathing reserved and maximum breathing capacity. Okay, so this is index between breathing reserve and maximum breathing capacity. Okay, and breathing reserve is the balance between this breathing maximum breathing capacity and respiratory minute volume. Okay, so this is the difference. Then if you wanted to calculate, okay, so here to determine this index, we have a formula also. That formula states that MBC minus RMB upon MBC into 100. Okay, so if you consider a normal subjects who is MBC is, suppose who is MBC is 116 liter and RMV, residual minute volume, is 6 liter. Okay, so here we can calculate it by using this formula. So it will be around, so it will be around 94.8%. Okay, so here dyspnea develops when the dyspneic index decreases below 60%. Okay, so this is all about this. Then next we have periodic breathing. Okay, so what is periodic breathing? Periodic breathing is the abnormal or uneven respiratory rhythm. Okay, and also it is of two types. First we have Cheney stroke breathing, and another we have biot breathing. Okay, so one by one, we're going to discuss about both of them. So first, we're going to discuss about Cheney stroke breathing. So this is the periodic breathing that is characterized by gradual change in force of breathing. Okay, so here we have gradual change in force of breathing. Okay, and there will be decrease in force of breathing, and that condition will result in apnea. Apnea means complete absence of breathing. Okay, and this is the most common type of periodic breathing, and it is marked by two alternate pattern of respiration. Okay, and that pattern is known as warning and vexing. Okay, so we're going to know about the region of or the causes of warning and vexing. So what happened initially during forced breathing, large quantity of carbon dioxide is washed out from blood. Okay, when partial pressure of carbon dioxide decreases, the respiratory center become inactive at that time. Okay, so it will cause apnea. So what happened during apnea, there is accumulation of carbon dioxide, and that accumulation is known as hypercapnia, and there will be reduction in oxygen tension. That reduction in oxygen tension is considered as hypoxia. Okay, now respiratory center become activated, and that will result in gradual increase in the force of breathing, and when the force of breathing reaches maximum, that cycle will repeat again and again. Okay, now we're going to discuss the condition. Okay, both the condition we're going to discuss. First, we're going to discuss the physiological condition when this type of breathing will occur. So in physiological condition, it occurs during deep sleep, high altitude, then also in newborn babies, then after severe muscular exercise, or also during hibernation. Okay, then also we have some pathological conditions. So pathological conditions like whenever there is increased in intracranial pressure, or during advanced cardiac disease, or in premature infants. So these are the condition in which this kind of changes can occur. Okay. Then also we have a cycle that we're going to discuss, the cycle of waxing and waning. Okay. So we talk about the cycle. So what happens whenever there is gradual increase in rate and force of breathing, that is known as waxing. So what happened? There will be removal of excess CO2, which will lead to decreased PCO2. Partial pressure of carbon dioxide will decrease, and there will be inactivation of respiratory center, and it will lead to gradual decrease in rate and force of breathing. That's considered as warning. Okay. Okay. Then another thing we have is Biot's breathing. Okay. So this is also another form of periodic breathing that is considered by the period of apnea and period of hyperapnea. So here both will be there. Apnea will be there plus hyperapnea. Okay, so waxing or waning basically does not occur in this phase, and after periodic apneic period, the hyperapnea will occur abruptly. Okay, now some causes are there of this type of breathing. So what happened during apnea? Carbon dioxide accumulated and stimulates the respiratory center, which leads to hyperventilation. So during hyperventilation, lot of carbon dioxide is washed out, so that the respiratory center are not stimulated and apnea will occur. Okay, so this is all about the virus breathing. Now, next we have the another condition, that is cyanosis. Okay, so what is cyanosis? As we can see, cyanosis is the bluish coloration of skin and mucous membrane. Okay, due to inadequate oxygen in the blood. Okay, this occurs due to inadequate oxygen in blood. Okay. Now, what are the causes of cyanosis? So, if we talk about the causes, so we have whenever there is presence of large amount of reduced hemoglobin. So, whenever large amount of reduced hemoglobin is there, so the quantity of reduced hemoglobin should be at least 5 to 7 gram per deciliter in the blood to cause this condition. Okay, then when it occurs, whenever this condition occurs, cyanosis is distributed to all over the body, and it is more marked in the region where the skin is very thin. Okay, so those areas are like lips, like earlobes, nose, fingertips. Okay, so these are the areas where this condition will be marked very easily. Okay, now next thing we have that condition when cyanosis occurs. Okay, so any condition which leads to high arterial hypoxia and stagnant hypoxia. Any condition that leads to arterial hypoxia and stagnant hypoxia. Okay, so cyanosis does not occur in anemic hypoxia because the hemoglobin content itself is very less. Okay, then another thing that it also occurs in condition when altered HB is formed. Okay, and due to poisoning, hemoglobin is altered into myth hemoglobin or self hemoglobin, which causes cyanosis. Okay, so the cyanotic discoloration is due to the dark color of these compounds only, and not due to the reduced hemoglobin. Okay, and also this condition can also occur in the condition like polycythemia, when blood flow is slow, and during polycythemia, because of increased RBC count, the viscosity of blood is increased, and it leads to sluggishness of blood flow. Okay, and also this cyanosis can develop during condition like heart failure, like hypotension, obstruction of blood vessel, then in the condition like thrombosis. Okay, so thrombosis in deeper veins usually. So these are the condition in which cyanosis can occur. Okay, the next we have the another condition that is known as emphysema. So emphysema is the obstructive respiratory disease in which lung tissues are extensively damaged. Okay, and damage of lung tissue will result in loss of alveolar walls. Okay, and because of this, elastic recoil of lungs is almost lost. Okay, now what are the causes? So the main causes are, it is found in the person who is the frequent cigarette smoker. Then whenever there is exposure to large exposure to oxidant gases, and in the condition like untreated bronchitis. Okay. Then if we talk about the development of emphysema. So usually smoke or oxidant gases irritate the bronchi and bronchioles, which leads to chronic infection. And also it increases the mucus secretion of respiratory epithelial cells, which causes obstruction of air passage. And also the cilia of respiratory epithelial cells are partially paralyzed and movement is very much reduced. Because of this, the mucus cannot be removed from the respiratory passage. Okay. Now, what are the effects of emphysema? So, in emphysema, airway resistance increases several times due to bronchiolar obstruction, so that the movement of air through respiratory passage become very difficult, and it is more pronounced during the process of expiration. And also due to obstruction of alveolar membrane and elastic tissue, the lungs become loose and floppy, so that the diffusing capacity reduce a great extent, so that the lungs compliance will decrease and the aeration of blood get impaired. And here enough oxygen cannot diffuse into the blood and carbon dioxide cannot diffuse. Okay. And also other effects like there will be obstruction, also affect in ventilation perfusion ratio, that result in poor aeration of blood. Okay. Then next we have the another disease that is known as Casson's disease. Okay. So Casson's disease is also known as decompression sickness. Okay, so what is decompression sickness? This is a disorders that occur when a person returns rapidly to normal surrounding, to atmospheric surrounding from area of high pressure like deep sea. Okay, that's why this Casson disease is also known as compressed air sickness, bends, driver's palsy. Okay, now what are the causes of this disease? So whenever there is high barometric pressure present at sea level, leads to compression of gas in body. And also it reduces the volume of gases. Okay. Now, if I look at the signs and symptoms that will be shown by the patient who is suffering from this disease, so the symptoms will be like severe pain in tissues. Okay, and those tissues particularly are joints. Okay, then sensation of numbness, tingling, pricking. Okay, then temporary paralysis due to nitrogen bubbles. Then also muscle cramps are noted. Then also occlusion is there, occlusion of coronary artery. Also, there is damage to tissues of brain. Then dizziness is there. Paralysis of muscles. Shortness of breath. So various signs and symptoms are there that will be shown by the person who is suffering from this disease. Okay. Now, what could be the treatment that should be given to the patient who is suffering from decompression sickness? So, if a person is affected by decompression sickness, first recompression should be done, and it is done by keeping the person in a decompression chamber. Okay. Then he is brought back to atmospheric pressure by reducing the pressure very slowly. Okay, so this is all about the decompression sickness and Gasson's disease. Okay, now next we have the another difference, the difference between respiratory failure. Okay, so here for respiratory failure, we have type 1 and type 2. So in type 1, the hypoxia is low levels of oxygen in the tissue and body could not meet the perfusion needs. Okay, so perfusion will not be properly in the body. And type 2, the condition of hypercapnia. Hypercapnia means there will be more and more CO2 accumulation. So hypercapnia is carbon dioxide retention that will affect the people with the condition like COPD. Okay. Then talking about the presentation, so the person will have the condition like bradycardia, tachypnea, dyspnea, cyanosis, syncope. And here the arterial partial pressure of oxygen will be less than 8 kilo. And here, in type 2, the presentation will be like confusion, flush, skin, sweating, dizziness, and the partial pressure will be greater than 45 mmHg. Okay. Then talking about the what will be the treatment and management that should be given to the patient. So there will be non-invasive ventilation, blood gases, oxygen therapy, and treat cause ECM. Okay. Then blood gas is also given in the condition of type 2, venture control oxygen therapy, then non-invasive ventilation, ECM. Okay, so this is all about the type of respiratory failure. I hope you find this class more helpful. So thank you so much for watching my class.